Okay, everyone, we have a couple minutes after the hour, so why don't we get started? So happy that we have you all with us today. Thank you for making the time out of your busy day to be part of Aphasia Access's first of our 2015 webinar series, where we'll talk about healthcare communication challenges today. I'm Todd Von Dijk, the Executive Director of Aphasia Access, and it's just great to kick off this educational series having Nina Simmons-Mackey with us. A couple of housekeeping pieces. You'll notice your microphones are all on mute. That's simply to make sure that the ambient noise doesn't interrupt anyone's learning during the webinar. We still want to hear from you, though. You should see a question feature. And if you have questions as we're progressing, we'd highly encourage you to share them with us through that electronic chat box, which will get back to me. And towards the end of the presentation, I'll help to bring the questions out to the forefront for Nina to react to. Likewise, we also want to hear from you if you're having any technical issues as we go. You have two ways of doing that. Probably the best is just to raise your hand. And if that happens, I'll reach out to you with a chat that's just between you and I. And I have myself and other members of the team here ready to triage anything so that we can make sure that your experience is the best it can be. We are recording this webinar. You'll have access to it after the fact, along with a couple other resources I believe Nina will mention. And the handouts were in the reminder email. You should also be able to download them from your control screen on the GoToMeeting or GoToWebinar platform. I think that's about it. We're excited to have you. We're excited for this conversation on such an important topic. And with that, I am going to click a couple of buttons, and we should be sending everything over to Nina to take us through today's conversation. Nina, can you hear us? Me.
I sure can.
The floor is yours.
Okay, I'm getting ready to throw up my PowerPoint. Let's see if we can get that up there. There we go. Okay. Again, I want to add to what Todd said. We're so happy that you all have logged on with us today. And as he said, what I'm going to talk about is communicating with people with language barriers in healthcare settings. And I know most of you are probably familiar or even very familiar with this information, but our purpose is really to present some arguments and some basic information that you can adapt to convince others of the importance of communication access in healthcare. So I'm hoping that each of you will be a conduit to a larger community to help change the healthcare environment for people with aphasia. So specifically, I'm going to talk about the importance of communication in healthcare, and I'll give you some statistics and some arguments that you might be able to take to others. I'll explain why I'm using the term language barriers, and finally talk about some evidence-based methods of reducing language barriers. Of course, this is my true confession slide. I'm a co-editor of a book that addresses the topic of today's talk. I'm also a consultant at the Aphasia Institute, and I'm president of Aphasia Access, the organization putting on this webinar. Okay, so the key questions that we want to start off with are, first of all, is it important to reduce language barriers in healthcare? And if so, how do we go about changing systems to support communication? First of all, to really situate the plight of people with aphasia in our healthcare systems, I think it helps to make the situation personal. So as you try to improve access, it's really helpful to use a personal story or a story from your clinical experience to sort of flesh out the whole meaning of communication access. So I want to begin this talk with a true story to hit home the importance to me of reducing communication barriers. A few years ago, my mother was admitted to a highly respected teaching hospital. She had a left subdural bleed that resulted in right hemiparesis and severe aphasia. In fact, all she could say was no, 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 which was a really terrible stereotypic utterance for a woman who was so optimistic and positive in her life. Upon admission, the neurosurgeon explained to me that he would like to control the bleeding first, and then in 2 or 3 days, possibly evacuate the blood and reduce the pressure on her brain. Well, the next few days were some of the most harrowing experiences of my life. In spite of my education and my years working in healthcare, I found the system almost impossible to negotiate. Nursing personnel rotated daily, so I never talked to the same nurse twice. The staff didn't even seem to communicate with one another, much less with me. No one seemed to understand aphasia. For example, the nursing assistant would ask my mother if she needed to use the bathroom, and guess what my mother would say? No, 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 when she meant yes, and the nursing assistant would turn around and leave the room. My mother would push the call button, and they would ask over the speaker, can we help you? And guess what she would say again? No, 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 and they would turn off the call light. In spite of written signs all over her room, on the front of her chart, and my constant exhortations to the staff, these kind of awful mistakes continued. My mother became increasingly anxious and depressed, and nursing began suggesting that she had behavior problems because she would try to get out of bed when they didn't respond to her needs. So in spite of my constant explanation, no one seemed to learn how to communicate with her. The culmination came when I was not able to contact the neurosurgeon, so I insisted on reading my mother's chart and found this entry: recommended surgery to patient, patient refused surgery. In other words, she said no, no to the surgeon's recommendation, and he accepted an aphasic stereotypic utterance as her informed choice. The neuro ward of this respected teaching hospital did not understand aphasia, did not know how to communicate with someone with aphasia, and the result was not only discomfort and emotional distress for my mother and my family, but also failed medical care. The heart of the problem was a pervasive, systemic breakdown in communication. The message, communication plays a critical role in ensuring patient and family well-being, quality of medical care, and even appropriate research. I'll come back to that in a minute. So first, let's consider the importance of communication in medical care in general. Communication is a core feature of healthcare. Communication issues are increasingly visible in government policy and healthcare literature. You've probably seen a lot about health literacy in the literature recently. That's defined as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Health literacy is now a required component of healthcare. This website takes you to a fact sheet on health literacy. And here's a link to instructions on writing in plain language. In fact, in the U.S., there was a U.S. Plain Writing Act that was passed in 2010, so it's a mandated requirement. So what's the difference between health literacy and communication access? Well, health literacy is a term that's really widely encompassing. It refers to the need to communicate in a way that's understandable for people of different cultures, people with low education, people unfamiliar with medical jargon, people who do not speak English well, and so on. Although the focus is not traditionally on communication disability, people with communication disabilities certainly should be included in any health literacy campaign. In our literature, that is the SLP literature, we tend to focus more on communication access. We're really addressing the same issue as health literacy, but our idea of communication access tends to draw from the disability movement. So both terms have the same goal, but derive from slightly different backgrounds. Both health literacy and communication access are relevant for people with language barriers, such as aphasia. So in your advocacy efforts, you might draw both from the disability literature and the health literacy movement. Now, why has health literacy and communication access come to the forefront so much in recent times? Well, one reason is that there's growing research to show that communication breakdowns are associated with very significant and widespread problems in healthcare. Ineffective communication is associated with all those things you see on your screen now: increased death, unnecessary pain, medication errors, extra costs, poor outcomes, and on and on. The World Health Organization reported that over 60% of medical errors are traceable to poor communication as a causal factor. In 2005, the U.S. Joint Commission estimated that of severe medical errors, between 60 and 70% were attributable to ineffective communication. Medication errors and lack of informed consent are reported as much more common among people with language barriers. It's also been estimated that up to 80% of malpractice claims in the U.S. are attributable to communication failures. Obviously, poor communication has significant medical, financial, and even personal implications. And it's even more important when we talk about the population that's had a stroke or a head injury, because this group is at a much higher risk for communication breakdowns. So, in fact, research in Australia found that 88% of patients admitted into a hospital stroke unit had one or more communication impairments. And over half of these were observed to have difficulty communicating their healthcare needs. In another study, people with communication disability were 6 times more likely to have adverse events than people without communication disability. There's also some research directly related to aphasia. People with aphasia are less likely to obtain written information about their stroke and about aphasia. They're often not given the opportunity to make their own decisions about medical, financial, or legal choices, or even discharge destination. Communication problems impact healthcare research also. Now, that might not seem like such a big deal, except think about it. Research serves as the evidence base for patient care. For example, in one study, 25% of potential research participants were excluded because of communication problems. So the research study was not accessible for people with communication barriers. Research suffers when potential participants are eliminated due to communication issues. And when we eliminate a segment of the population from our research, we run the risk of drawing inappropriate conclusions. So poor communication impacts not only the quality of medical care, but the research that informs those very medical practices. Another reason that health literacy or communication access has gained increasing attention is that communication problems have a potentially devastating impact on patients and their families. We know that communication is integral to almost all of our life situations. Without effective communication, every relationship, every life role, and almost every life activity are at risk. It affects well-being. It affects self-esteem and relationships and emotional health. So, for example, research shows that stroke survivors with aphasia have a higher incidence of depression and psychological distress than stroke survivors without aphasia. And certainly we can understand this based on the impact of communication disability on life, as I said a minute ago. But also, many people with aphasia and their families have told me about the impact of early hospital experiences and their feelings of helplessness and isolation that really colored the whole rest of their trajectory of recovery. Also, research shows that people with aphasia tend to be alone and inactive in hospitals. Aaron Gadecki and colleagues found that staff and visitors talk to stroke survivors with aphasia significantly less than to stroke survivors without aphasia. So here's the potential picture we draw from these research findings. People with aphasia spend lots of time alone in their hospital rooms, not communicating. When healthcare staff do interact with them, it is often frustrating, emotional, or can even be dangerous. People with aphasia get insufficient information about what happened or what to expect. They're often not included in choices as simple as whether to have tea or coffee, or as complex as where to go to live or whether to have a surgical procedure. They're at risk for depression, and their families are at greater risk for depression also. Given this, it's obvious that we need to make efforts to reduce language barriers, to reduce the wall of aphasia. And there's substantial support for doing this at the government, professional, ethical, and statutory levels. In her authoritative chapter on communication, access, rights, and policies, Jennifer Horner listed wide-based support for communication access for aphasia, and that included international declarations and covenants, such as the UN Convention on the Rights of Persons with Disabilities. There are constitutional rights, for example, in the U.S., the right to equal protection under the law. There are statutory rights, such as the Americans with Disabilities Act or the ADA Amendments Act of 2008, and similar acts in Canada that require reasonable accommodations so that people with disabilities can participate in activities, services, work, and their health care. There are standards and guidelines within professions. So, for example, in the U.S., the Joint Commission has guidelines for hospital accreditation that stipulate clear requirements for patient-provider communication. There are also ethical standards pertaining to things like capacity, competency, and surrogate decision-making. And finally, there are court cases that have supported the right to decision-making and communication access for people with communication disability. Communication access is also recommended in a variety of guidelines, particularly in the stroke literature, but also in other contexts. More recently, Aphasia United, which is an international umbrella organization for aphasia, went through a long consensus process to identify the top 10 best practice recommendations for aphasia. 2 out of the 10 recommendations concern reducing language barriers. So one says that all health and social care providers should be educated about aphasia and trained to support communication in aphasia, and the other says that information should be available in a communicatively accessible format. Now let me back up a minute. I've used several different terms: health literacy, communication access, and language barriers. All are relevant. But I use the term language barriers in the title because I think it's a way to help explain how aphasia fits in this larger issue of healthcare communication. A language barrier occurs when people who try to communicate do not share a common language. It can affect speaking, understanding, reading, and writing. Intelligence and inherent competence remain intact, but these are masked or hidden by the language problems. In effect, someone with a language barrier knows more than they can say, as they often use the terminology at the Aphasia Institute in Toronto. So, for example, if I show you this, now have a look at that. What are people doing out there that I can't see? Did you respond to this message? Probably you don't understand it, and probably would not be likely to act on it, even if it were shown, say, in a movie theater. Even though it says, emergency, fire, leave your building now. So even though you're an intelligent adult, you experienced a language barrier. Using examples like this helps people who don't know much about aphasia to grasp the issues. So suppose I showed you this. Here, use of pictographs overcomes some of that language barrier. So this kind of example helps other people understand the issues faced by people with aphasia in a simple and straightforward manner. So, aphasia is a prime example of a language barrier. Aphasia occurs in approximately a third of people diagnosed with stroke and many other people who have other etiologies like traumatic brain injury or a tumor in the language areas of the brain. So there are lots of people that have language barriers associated with aphasia. But there are other examples of language barriers, such as non-native speakers who encounter language challenges. The U.S. Census reports that 21% of respondents spoke a language other than English at home, and there are very similar statistics in Canada. By extrapolating from the U.S. Census, it was determined that 23 million non-English speakers are likely to use the healthcare system. So 23 million people are at risk in the U.S. for receiving substandard care merely because they're not fluent in English. One author that I read made this very compelling statement. Should the language you speak determine how long you live? To me, that's a really impactful way of looking at the inability to communicate in healthcare, and this could easily apply to people who speak aphasia. Also, some individuals with dementia experience language barriers, and this population is growing with all of us aging baby boomers. Communication support helps people with dementia participate in their own health care, as research is now showing. So many people in our healthcare systems are at risk for communication failures due to language barriers. So if we're going to argue for improved communication access, we're talking about a lot of people. So given the kind of low awareness of aphasia, it really helps us use research on non-English speaking groups and dementia to sort of bring the issue to a broader audience. Okay, so let's switch gears here. What can be done to overcome language barriers? Well, traditionally, people with communication impairments or language barriers such as aphasia are referred to speech-language therapy. And probably most of you listening to this are probably speech-language pathologists who work with the individual to reduce the language impairment, to improve functional communication, to improve participation. And there's a strong evidence base summarized in the reviews that you see here that support direct aphasia therapy. But this approach focuses largely at the person level. It directly works to change the communication of a person with aphasia. In a study that I did with Ora Kagan and colleagues, we found that many healthcare providers consider that this is the only avenue to improve communication for people with aphasia in healthcare. So in that study, we interviewed 3 teams of healthcare providers. and almost all of them considered communication of the person with aphasia to be the responsibility of the speech-language pathologist. So we have to ask, is direct aphasia therapy the answer or the whole answer? And really, it's yes or no, or yes and no, I should say. Yes, it's very important. People want to get better. They want to improve their language processing, so it's important that people with aphasia have access to speech-language therapy. However, it's not the whole answer to reducing language barriers. And of course, the problem is that language recovery can be slow. It might not be fast enough to prevent communication failures. Focusing only at the individual level overlooks systemic communication issues, problems in how the institution deals with communication breakdowns. For example, the daily rotation of nursing staff from different wards in my mother's hospital situation. And finally, many people with aphasia do not fully recover language even after direct therapy. So people end up having communication breakdowns before language recovery has occurred, or they get better but still not good enough to avoid communication failures. So of course, an additional approach is needed to manage language barriers. This involves addressing systems level issues, things that the institution and healthcare personnel can do. At the systems level, we work on changing the environment around the person with aphasia. That is, make a communicatively accessible environment. This systems approach to reducing language barriers helps reduce the risk of communication failures. It increases staff satisfaction because it reduces their frustration in dealing with people with communication issues, and it avoids negative incidents. It helps people with aphasia participate in their own health care. It increases patient and family satisfaction. And most of all, it provides models for family members and patients about how communication can actually work. They witness how communication can be facilitated or supportive, and they see how they might be able to do this over the long term. So how do we actually modify communication in a systems approach? The key is providing communication support, which is defined as anything that helps improve someone's successful participation in communication. And so that can be a wide variety of things that occur around the person with aphasia, like the knowledge and skill of people in the environment, material resources in the environment, or adaptations to the environment itself. Communication supports are needed whenever and wherever someone needs to communicate. So, for example, this just partial list of things that might be needed, that the person with aphasia might need to do in an inpatient environment. Pretty extensive, and it goes on and on. So the person with aphasia might use the nurse call system. They might need to consent to a medical procedure, communicate their basic needs, select menu options, follow a daily schedule. The most powerful communication support involves trained and skilled communication partners. A partner is anyone who communicates or might communicate with the person with aphasia. The person who answered my mother's nurse call system was a communication partner, and apparently one who really needed some training. Doctors, nurses, therapists, clerical staff, even housekeepers all play a role in ensuring that a person with language barriers is safe, comfortable, and gets proper care. Skilled partners typically receive specialized communication partner training. And if we extend this idea, then healthcare personnel should receive communication partner training. It's available in a variety of formats, typically delivered by a speech-language pathologist, but not necessarily. The most well-known and widely researched approach to training healthcare personnel, as well as family members, is supported conversation for adults with aphasia, or SCA. The Aphasia Institute in Toronto offers this training program and also trains trainers so that effective partner training can expand to multiple settings. Other approaches, such as Spark or Better Conversations with Aphasia, also are training mechanisms. The Better Conversations with Aphasia was really developed for family members and regular partners, but it is an interesting program that's free online. And you might be aware of other approaches and training resources out there. There is strong evidence supporting partner training. In a review in 2010, the reviewers concluded that communication partner training is recommended for providing environmental support and communication access in aphasia. A review by Salter et al. Arrived at the conclusion that partner training improves communication for people with aphasia. So what are the skills of a trained communication partner? Well, first of all, they understand the presenting problem. So there's knowledge of what is aphasia, how it differs from dementia, and so on. A skilled partner projects an attitude of respect and care. A skilled partner fluently uses support strategies, so the partner knows how to use multimodal communication, how to simplify utterances without sounding patronizing, and so forth. A skilled partner knows how to use resources to support communication, such as pictures or written choices. So effective communication skills require a skilled partner with knowledge of a variety of strategies and behaviors, and also appropriate tools or material resources that are available to help with the communication support. Material supports are things like pictures, drawings, pictographs, written keywords, rating scales, communication books, and so forth. Material resources can be generic and very simple, such as a yes/no card to help the person with aphasia respond to questions, or tools can be designed for specific uses, such as this visual pain rating scale, which is widely available in most healthcare settings. This scale is from the Assessment for Living with Aphasia and is used to help people with aphasia rate their satisfaction with various life situations. There are a host of activities in hospitals and in rehab that can be modified to be aphasia friendly. So, for example, informed consents can be made more communicatively accessible. Educational materials, case conferences, schedules, menus, and other aspects of these settings can be made more accessible to people with aphasia. And there are commercially available tools for communicating in healthcare, such as these booklets published by the Aphasia Institute in Toronto. Or you can use materials for specific uses and create them yourself. Many of you are familiar with creating aphasia-friendly resources, and there are quite a few sources out there for information on how to make something aphasia-friendly or communicatively accessible. So, for example, if the radiologist wants to describe the MRI procedure, they not only should just speak the directions, but they can use clear pictures to support their talk. Here's an instruction page regarding a minor surgery. Here's an example of a page from an aphasia-friendly satisfaction survey, so that a person with aphasia, with the help of a trained partner, can give feedback on a program. Here's one you're probably familiar with, a typical communication board that you often find in patient rooms. but I might add, rarely see being used effectively. Communication boards, to me, are a great example of the right idea, but the wrong implementation in most circumstances. Here's a quote that I really like about communication boards in hospitals. It takes approximately 10 minutes to locate a communication board in most intensive care units. And once staff finds the communication board, often a sheet of paper copied several times and difficult to see, there's little understanding about how to use such tools effectively to support patients who are unable to communicate. This lack of awareness, limited time given to communicate, and poor utilization of available resources all contribute to a health system that, despite the movement towards patient-centeredness, is fundamentally not focused on the patient's need for effective communication. So materials such as the communication board are adjuncts to an interaction with a trained partner. They don't just work on their own. Communication support is a process that requires trained people and appropriate resources and a dynamic interaction with the person with aphasia. So the partner should mediate the use of resources. We can't expect the person with aphasia to just pick up a communication book or a communication board and start pointing. It's the trained partner that introduces and uses the resource to effectively communicate. And in my opinion, this is one of the biggest sources of failures of these sorts of approaches, is a lack of a deep understanding by staff about their role and about the skill that's required to appropriately support communication. And here's the rub. Most of us know what should be happening in healthcare, but how do we actually get changes in an environment that's as complex as healthcare? Implementation is a big hurdle in healthcare settings. Many of us are skilled in direct aphasia intervention. We know how to do that, but we're less familiar with how to change the behavior of large groups or systems, such as healthcare providers in a large facility. Efforts often involve purchasing communication boards or offering in-service education to targeted groups like nursing staff, and then the methods are disappointing, just like the earlier quote about communication boards. In fact, a couple of years ago I wrote, and pardon the egocentricity of quoting my own self, but I wrote, in spite of the documented effectiveness of partner training and increasing pressure to improve patient-provider communication in healthcare, there's little evidence of widespread systems changes in communication access for people with aphasia in the United States. We're just not there yet. The problem is, in order to ensure actual change in everyday practice, we can't just do some in-services. We need a broader approach to address system or infrastructure change. And this sort of approach is typically addressed in knowledge translation or implementation literature. So the literature that I'm talking about tells us things like, once something is published in the literature, it typically takes a minimum of 7 years for uptake of this new knowledge to get into practice. So we really need to look at how we go about moving this knowledge to action gap to a shorter time period. Any new practice or new knowledge is taken up only if it fits within the policies and everyday activities of a setting. And so somebody might be beautifully trained, but if they go back and what they need to do in their setting doesn't work, it's going to be lost. In order to change a system such as healthcare, we need to identify barriers that impact the uptake of support practices, identify facilitators that will help with uptake, and many of these are setting specific, so you have to look at your local context. How do we proceed? Well, the first thing to do is to identify the key stakeholders. Who actually needs the training? Who needs to approve the new practices or the policies? Who needs to approve the time and money needed? Who will evaluate the success of the practices? So you need to get buy-in at each of those levels. In fact, to implement systems changes, it helps to think about stages of effective systems change. At stage 1, stakeholders are really not aware of the targeted practices or the knowledge. They don't know what aphasia is. They don't understand the consequences of aphasia. So our aim at this stage is to raise awareness, to let people know about the population with language barriers and the risks to their care. At the second level, people develop an awareness of a problem, but they don't see the relevance to them. So the nursing assistant realizes the person has aphasia, but really doesn't know that her own communication skills directly impact that person's care. Or an administrator might think that communication access is somewhat tangential to the institutional mission. So at this stage, we're trying to persuade each set of stakeholders what's in it for them. So we want to know what are the rewards and who would be moved by what reward. And you see some examples of the types of rewards that might impact people. Stage 3 involves recognition of the problem and development of strategies to change behavior. For example, your facility might form task forces to work on creating a more accessible facility. Knowledge transfer research suggests that at this stage it really helps to engage people who actually need to make the changes. So you want to have frontline nursing staff, personnel involved, and help them address the barriers and think of what would work. So at this stage, you might see things like developing ways to identify communication risks. Who needs communication support? And then implementing some kind of universal alerts or IDs so that everybody that communicates with that person sees that they're at risk. So something like maybe colored wristband or stickers above the bed. It might involve, might involve development of explicit policies and procedures for staff training, identifying sources of fiscal support, identifying logistical needs, identifying how staff will be rewarded for supporting communication. Stage 4 involves knowledge to action. So here, the plans are implemented on a day-to-day basis, and an ongoing system of evaluation determines what's working and what's not working. And there are lots of ways to evaluate different aspects of a communication access program. So you might do actual quizzes of people's knowledge. You might include aspects in performance evaluations. There might be audits of practices. There might be on each unit a champion or a mentor that will support and help staff implement so that they can watch them with a particular person and provide feedback. Or it might be surveys of staff or patients. For example, the communicative access measures for stroke are web-based measures that will be going live fairly soon if you go to www.aphasia.ca. And these are 3 surveys that are completed, one by administrators, one by frontline staff, and one by patients that help you determine the communicative accessibility of a particular program or facility. So, in summary, there are compelling reasons to improve communication access in healthcare. There's evidence-based methods of doing so. Our mission at this point is to implement appropriate methods for changing healthcare systems. Promoting communication access to reduce language barriers for people with aphasia and others is a critical need, and we really do know how to do this. In fact, communication support should become ubiquitous just like infection control. We don't skip hand washing or putting on gloves to save time. Healthcare providers shouldn't skip the necessary steps and time for effective communication. And Aphasia Access wants to help as much as possible. So in about a week or so, you're going to be getting links to a series of 3 very short videos that demonstrate some fundamental techniques for communicating with someone with aphasia. We don't really think most of you are going to need those, but what they're for is for you to use to reach out to other people and demonstrate some of the basic fundamentals of communication access. We'll also be sending you a communication access checklist that might be useful. And I would encourage Aphasia Access affiliates to continue the discussion of communication access. Share your resources and your ideas on the peer-to-peer networking site. Or if you want to email me with ideas and suggestions, I'm happy to collate these and include them in the next newsletter. So we can all work together to reduce communication and language barriers. It's really something that's important. And now I think we have some time for questions.
Sure, of course, Nina. We have 2 questions we've received, and if anybody would like to ask questions, just go right ahead and use the question bar. Question 1, Nina. Are there studies of this actually working in healthcare?
Yes, there are studies that are being done, but what's interesting is the studies that are out there are mostly whether people can be trained and acquire the skills. Most of them are not larger implementation studies. So there are a few studies that have come online, one in Denmark and one in the UK, and a couple that are being done in Canada that look more at an implementation level. But that's what really needs to be done now. We know that people can be trained, and we know that they can use it with people with aphasia and language barriers. But what we haven't proven through an evidence base is how it can be integrated into a larger system. And that's really where we need to go with it.
Okay, I've got one more question. Improving communication in healthcare is an important goal, but how can busy clinicians and speech pathologists do this with their more than full clinical caseload?
Ooh, scary question. It's a really critical question. I think that was one of the things that study that I did with Aura and colleagues really sort of pointed out was that there's a tendency to think that it's the responsibility of the speech language pathologist. And I think speech language pathologists tend to think it's their responsibility too. But it's when we're talking about a system level change, it's the system that has the responsibility. And so speech language pathologists really need to get to the people that are the decision makers, the people that manage the money, and persuade them that this needs to be done and that they need to put resources towards that. So whether it's the speech language pathologist or others in the system, that needs to be someone's job. You can't expect someone who has a full caseload to, in their spare time, be going out and trying to change a system. Certainly, speech language pathologists have the knowledge and the skill to do that, but it's way beyond what can be expected in the way most of the systems work. So it's really, I think I mentioned that it's an advocacy issue, advocating that this needs to be done and that people that have the resources, the time, and the finances to do it are available.
Okay, 2 more coming in. Sometimes graduate students are exposed to these concepts and want to use them in internal practice. Can you recommend ways that students can approach supervisors about these newer concepts?
Oh, well, I think one thing is to, the resources from this webinar is a good way to start, to demonstrate, to be an advocate and say, that you're just learning about this stuff and it's really fascinating to you. This is a great handout to look at, and actually go to them and ask them for their help in how they can learn more about it, how they can proceed. So, my experience with supervisors, external placements, is that, as a student, you're vulnerable and you don't want to go in and make your supervisor feel stupid. You don't want to go in and make them resent you as a student. So I think you have to approach it in a very delicate way, that you're asking them to help you learn more about it and asking them if there's a way that you could try out any of this stuff in this system and maybe go from there. And if that doesn't work, you'll be out soon and can do it on your own.
Next question. How do we as speech therapists who don't work in hospital or rehab facilities implement these practices into healthcare settings?
Well, I think, if you're affiliated with any healthcare setting, if you're a patient in a healthcare setting, you can certainly approach managers or administrators and talk about the need for these kinds of things. It's possible that you could even develop an advocacy talk that you go in and give to different healthcare settings. I mean, I would encourage people that are out maybe in private practice or in aphasia centers to develop programs that you could even charge a small amount for, so that you can be reimbursed for your time, but contextualize it as this is required by accreditation. It's required by law with the Plain Language Act of 2010. It's required by good practice. So the Aphasia United Practice recommendations, and we're here to help you if you would like to implement it.
Next question. The
And
questioner.
if anybody out there has suggestions, you can write that in the question thing, or go to the peer-to-peer networking afterwards and post some ideas. I know people out there have some good ideas.
This question starts with just a note that this work is so important. And the question is, while therapists wear a lot of hats, advocating is so important. What would you suggest would be a good first step a therapist could make with inpatient facilities?
I think a good first step is identifying who has the power to make some changes, and then going to them, having a little meeting with a story very similar to, you can even use my mom's story, or I'm sure all of you have similar stories that you've run across, and starting with something that sort of gets to the heart, and then maybe bring a handout of statistics that show how important it is.
Then we have a question. Are you optimistic that this kind of systems change is widely possible?
Yes, I am optimistic. I don't think it will be an easy fix. I think some systems are much more amenable to it than others, but it's got to happen. I mean, as systems have become much more organized and mechanized, communication, patient-provider communication has actually gotten worse. And so unless we do something about it, medical care is going to suffer more and more. And so I think I'm optimistic from a negative and a positive standpoint.
We also have a couple of questions wanting to know how the story with your mother turned out.
Well, actually, it turned out okay. She's doing fairly well. After I realized what was going on, we actually got a medevac and got her out of that hospital and brought her to a hospital near where my sister lives. It's much smaller, that was much more responsive, and they have been very supportive. And so she's doing pretty well. She's actually, has almost minimal sign of aphasia now.
Great. This questioner loved your fire emergency example and asks, as advocates and speakers on this cause's behalf, are there other resource bases where we can find similarly striking examples?
I'm not sure of that type of example. I think one of the things that we really want to do through Aphasia Access is to develop those kind of resources. And I know that we have a resource exchange working group that's working on developing aphasia-friendly materials and resources. And so that's something that ought to go on the list, because I'm sure there are things out there. I can't pull them off my head right now because that one I just kind of made up. But it would be something really useful, I agree.
Okay, we'll get to 2 or 3 more here. How can we work together with our colleagues in stroke recovery to make training and supportive communication strategies mandatory for anyone involved with stroke survivors in the hospital and community?
Yeah, I guess the first step is to get it written into hospital policy. So my experience with hospitals is that if it's not part of policy and procedure, it doesn't really happen, or it happens once and then it never happens again. So it needs to be incorporated into hospital policy, and that's where um, are needing, possibly starting on a smaller level, like maybe just in the inpatient rehab unit, which certainly inpatient rehab is much farther ahead of the learning curve on dealing with people with communication barriers. So looking at how that can be included in their policy and procedure manuals, how training can be mandated as people are hired, and possibly yearly brush-ups. So I would encourage that to be the first step, to going to people that are in a position to get that written into policy.
Are there
And the
chart?
other thing related to that, whoops, sorry.
Nope, Nina, your turn.
The other thing related to that is it's so important to talk to managers and admin. If you're on a rehab unit, maybe talking to the head nurse and to the physiatrist who runs the unit, or whoever runs the unit, about what the reward system is. If the nurse who has 6 people with aphasia has the same caseload as the nurse who has 6 people with arthritis, it's really not going to be fair, because their time constraints are going to be so much different. So looking at those sorts of things is important.
Are there charts or booklets with good picture cues for medical needs for use by first responders, hospital and medical care facility staff, and so on? Would also welcome suggestions for ways to educate and train staff to be good communication partners in medically important situations.
Oh gosh, well, do you have another 5 hours? Yes, there are some good resources out there. I think that handout that I said would be coming via email, the Communication Access Checklist, has some resources included in it. So that's one answer to that. The other answer is that I know that there are, pictographs that are available. For example, Aphasia Institute is going live with their Participics, and you can search through and find specific pictures that relate to specific, say, medical procedures. And they have booklets for dealing with your diabetes, talking to your nurse. So those are very specific to narrow areas of medical care. And that's really what's needed often, more than some generic one-page communication chart. And I think the second part was about instituting training, and I think that's really a huge topic. There's a lot written on it. I don't really think I have time to go into all that here, but there are methods of training that have been pretty well proven effective.
3 more questions.
Mm-hmm.
How can I participate in creating aphasia-friendly materials for healthcare personnel?
Well, you could join Aphasia Access and start a working group for creating aphasia-friendly materials. The other thing is to just get together other people that you know are interested in this and begin to identify materials that are needed. You know, there are different things that are needed for every kind of situation, and so I'm not sure how to tell you to start because there may be things that are particularly relevant to your situation. I know one of the things that the Resource Exchange Working Group is working on is aphasia-friendly consent forms. That's their first topic. And what they're going to do is I'm not sure how often, like each quarter or so, they're going to have a new topic and work on developing materials and making them available for specific aphasia-friendly resources.
Are there models or Are there models or suggested strategies to get legislators or policymakers involved in implementing necessary changes?
Well, I don't really know the answer to that per se. I know the Adler Aphasia Center in New Jersey has been doing some really impressive work on influencing their legislature. And so I would encourage you to contact them, that's Adler Aphasia Center, and find out what they've been doing because they've made some significant inroads in that regard. It's really an important thing. It's something I know the NAA has talked about that in the past, about needing to influence legislation. It's a huge issue that needs much more organized support.
And the last is a number of comments, just so everybody is aware. A lot of you have said this is a great topic for us to infuse and include in our interpersonal education, interprofessional education, and practice at the pre-professional level. And I just think that's a theme through there that I wanted to call out and thank you all for reinforcing the importance of what Nina talked about today. Some of you did ask questions that I think are very appropriate to a specific situation, your individual situations. I will pass those along to Nina so that she can reach out to you directly and converse on that. I think that that's probably the appropriate moment to talk about specific scenarios or specific challenges that some of you have raised. I just want you to know we heard you and they're not just going to go into the abyss. We'll be following up with you offline for those conversations. I do want to say thank you to everyone. I think this was great. Thank you to Nina for leading us in this first conversation. And as she mentioned, there's a couple ways to keep the conversation going, and we'll send you an email tomorrow with them, along with a brief survey to get your feedback. But don't forget to go to the peer-to-peer community inside the Aphasia Access website. If you're not sure how to log in, during the webinar, I added a third handout to our control panel, which is a step-by-step instruction guide to going in, logging on, and asking questions or sharing your reactions. You can also find Aphasia Access on Facebook at facebook.com/aphasia access. As I mentioned, this is the first in our series of webinars. We have 2 more left in 2015. Registration for those will be up and online in the next day or two. You can keep up with our training resources, which are growing by the month, at aphasiaaccess.org/training. Thank you again to everyone who participated. Just by being here, you're making a statement about the importance of communication access in a healthcare setting, and we look forward to welcoming you down the road again. Have a great day.
Bye, everyone.